Welcome to our IBD Learning virtual program, Beyond the Belly, IBD Symptoms Outside the Gut. My name is Tina Collison, and I am the Health and Wellness Director at the Norfolk Family YMCA in Norfolk, Nebraska. I have had Crohn's disease for 19 years, and I had a total proctectomy and permanent ileostomy last October. I have 3 adult sons, Kale, Max, and Tate, and my middle son, Max, was diagnosed with Crohn's disease when he was only 11 years old. I am pleased and honored to be your moderator tonight. Crohn's disease and ulcerative colitis affect not only the gut, but also other parts of the body, such as our joints, skin, eyes, and liver. Tonight's webinar, Beyond the Belly, IBD Symptoms Outside the Gut, will help us understand complications affecting many IBD patients like arthritis, skin rashes, eye inflammation, and liver complications such as primary sclerosing cholangitis. We hope you will learn strategies for communicating these symptoms, monitoring and treating these complications to improve your quality of life. In order to make the program more interactive and find out how much you've learned tonight, we'll be asking 2 questions via a poll on your screen now. Number 1, are symptoms outside the gut more common in Crohn's disease or ulcerative colitis? What do you think? Is it Crohn's, UC, or are symptoms equally common in both diseases? Number 2, what is the most common IBD symptom outside the gut? We listed here a few symptoms people may experience. Which do you think is the most common? I'll give you a few seconds to make your selections. At the end of the presentation, we will ask these questions again and see how much you have learned tonight. Thank you for your participation. It looks like most people actually picked that they can occur the same in both diseases. And the second question, it looks like the highest percentage was peripheral arthritis. The information shared is meant to be for educational purposes only and should not replace any advice or guidance from your own healthcare professional. The program tonight will be recorded and posted on the MyIBD Learning website, which is www.crohnscolitisfoundation.org/MyIBD Learning. And everyone who registered for the program will receive a link with the recording next week. We want this to be as interactive and as engaging for you, so we encourage you to submit your questions through the Q&A box, which can be found at the lower part of your screen. Following our expert discussions, I will moderate a Q&A session with all of our panelists and will address as many questions as we have time for. Tonight, we have the opportunity to hear from Dr. Elizabeth Scoville. Dr. Elizabeth Scoville is an assistant professor of medicine at Vanderbilt University Medical Center. She completed her internal medicine residency at Massachusetts General Hospital in Boston, Massachusetts. She came to Nashville for her gastroenterology fellowship at Vanderbilt. After completion of fellowship, she joined the VUMC faculty in 2017. Her clinical practice focuses on inflammatory bowel disease patients in the VUMC IBD clinic. We understand the importance of your questions, and we want to ensure we will answer as many of your questions as possible. Tonight, we are honored to have Dr. Alexander Levy monitoring the Q&A box. Dr. Levy is an assistant professor of medicine in the section of digestive diseases at Yale University. He also serves as the program director for the Yale Inflammatory Bowel Disease Fellowship. Dr. Levy's clinical and research interests include complicated perianal Crohn's disease, acute severe ulcerative colitis, and complementary therapies for IBD. He has co-authored several published articles, scientific abstracts, and book chapters related to Crohn's disease and ulcerative colitis. Dr. Levy is actively involved in IBD education with a focus on improving patient education in underrepresented communities. He is also a member of the Patient Educational Committee for National Scientific Advisory Committee for the Crohn's and Colitis Foundation. If you have a question for Dr. Levy, please type it in the Q&A box. He will do his very best to answer as many questions as he can, keeping in mind he may not be able to address every question. Following Dr. Scoville's presentation, Dr. Levy will join her for a live Q&A session. Listed here are our speakers' financial disclosures. Now, let's get started with tonight's presentation. At this time, I'd like to welcome Dr. Elizabeth Scoville.
Thank you so much, Tina, and thank you everyone for logging in and spending part of your Tuesday evening with us. So today we're going to talk about IBD symptoms outside of the gut. These are called extraintestinal manifestations, or you'll hear us say EIMs during this talk for short. As we all know, most symptoms of inflammatory bowel disease occur in the gastrointestinal tract within the intestines. However, IBD is a whole body disease, and symptoms can occur in other parts of the body as well. This is what we're referring to when we talk about extraintestinal manifestations, or EIMs. Most of today's talk will be dealing with what we call primary EIMs, which are inflammatory conditions that occur outside the intestines that occur in individuals with IBD. Again, that's the focus of today's talk. But sometimes you may hear people talking more about what we consider secondary extraintestinal manifestations, which are conditions that occur outside of the GI tract, which occur as a result of intestinal inflammation. And these can also kind of be considered complications of IBD. Good examples of this would be things like venous thrombosis, which are more common when there's intestinal inflammation, or a great example is osteoporosis, which can happen because of poor absorption, poor nutrition, or steroid use over the course of a disease process with IBD. We won't focus a lot on secondary manifestations of disease today for the sake of time. We can go to the next slide. So extraintestinal manifestations, as we've already been introduced, can involve multiple parts of the body. They most frequently involve the musculoskeletal system. Joint pains are an example of that, the skin and the eyes, but it can also affect other parts of the body, such as the liver, which we'll talk about also today. Next slide. Extraintestinal manifestations are very common. That's why we're having this talk today, and that's why so many of you have logged on today. Approximately half of IBD patients will experience at least one extraintestinal manifestation over the course of their disease if you follow things long enough. Although this does vary greatly between studies, and you'll see some variation in any time we present numbers. And that's in part because we aren't very good at reporting these. And there's some variations in the way they report these. So bear with us anytime we look at numbers. Of patients with extraintestinal manifestations, most report one, but it is more common once you have one extraintestinal manifestation. You're more likely to develop another. And about 27% of patients will also report two or more manifestations. So having one extraintestinal manifestation increases the likelihood of developing additional EIMs. And peripheral arthritis is the most common one of those. So you guys got that one right in your questions. Next slide. This is just a schematic that shows kind of how we think about diagnosis of extraintestinal manifestations. And it's really important to realize that extraintestinal manifestations can actually start before someone gets a diagnosis of IBD. So of patients that ultimately report having an extraintestinal manifestation, about 25% of those report that their EIM actually started before their IBD was diagnosed. And there are some EIMs that are so highly associated with IBD that it actually prompts a physician to start looking for IBD. PSC that we'll talk about later is one of those. And this again, kind of emphasizing that if you follow people for a very long period of time, say 30 years or so after a diagnosis, about half of people will eventually have an extraintestinal manifestation. Next slide. So extraintestinal manifestations are common in all individuals with IBD, but they are slightly more common in those with Crohn's disease. And I would say those of you that said they were about the same are actually also correct because it isn't that different. But in most studies, particularly large meta-analysis and kind of larger reviews, suggest that they are a bit more common in Crohn's disease. When we look at specifically joint, eye, and skin extraintestinal manifestations, about 35% of patients with Crohn's disease will report one of these, compared to 27% of ulcerative colitis patients in a large review of studies related to EIMs. EIMs are roughly equivalent in men and women, although some individual EIMs may vary between men and women. For example, ankylosing spondylitis and primary sclerosing cholangitis are more common in men. And extraintestinal manifestations in general tend to be more common in smokers, as are most things in IBD, unfortunately, particularly skin and joint manifestations. When we think about extraintestinal manifestations, one of the main classifications of how we think about these is how they behave or react compared to the intestinal IBD. So there's one group of extraintestinal manifestations that parallel the course of intestinal IBD. For example, when the bowels are active, the extraintestinal manifestation is active. And for these, generally, when we treat the underlying intestinal disease, the extraintestinal manifestation gets better. There's another group of extraintestinal manifestations which tend to follow a course that's independent of intestinal IBD. And these generally have to be treated somewhat separately from intestinal IBD. Fortunately, though, many of the drugs and treatments that we use do tend to overlap. And with all things in IBD, there is some overlap between these two kind of big buckets of extraintestinal manifestations, as we'll talk about. So there's always a little bit of gray zone and a little bit of disease, or a little bit of overlap in this disease process. You can go to the next slide. And this is a broad overview of kind of extraintestinal manifestations that we'll talk about today and which of these categories that they fall into. Some peripheral arthritis, for instance, tend to parallel the course, although there's some overlap there. Whereas others, like primary sclerosing cholangitis, tend to follow a very separate course. And we'll go through each of these individually throughout the talk. Next slide. So we'll start out with skeletal or joint manifestations as we deep dive into each of these individual manifestations. These are the most common, as we have mentioned, so we'll spend some time on these. Next slide. So when we think about skeletal manifestations or joint manifestations, we're primarily thinking about arthritis. Arthritis is joint pains, essentially, and that's the main presenting symptom of arthritis. This is the most common extraintestinal manifestation of IBD. And when we think about arthritis, we're thinking there's several different classifications, but two main types that we're thinking about are axial arthritis, which affects kind of the joints there in the red, the midline joints, and peripheral arthritis, which affect the smaller joints on the periphery of the body, like the knees, shoulders, wrists, ankles, and things like that. Next slide. Peripheral arthritis gets even more complicated because there are two types when we kind of think about peripheral arthritis. Type 1 involves fewer joints. It tends to involve slightly larger joints. It almost always comes along with intestinal inflammation. This is what we kind of classically think about with IBD-associated peripheral arthritis. Type 2 tends to involve a few more joints, say more than 5, and it tends to involve smaller joints. And the characteristic of type 2 is that it can come without intestinal inflammation, or it can follow kind of a separate course than inflammation. So this is a little bit of that gray zone. The good news is, though, that peripheral arthritis, it is the most common extraintestinal manifestation, but the good news is it generally does not cause joint damage, unlike some of the axial arthritis and other types of inflammatory arthritis, like rheumatoid arthritis. Next slide. Axial arthritis includes predominantly sacroiliitis and ankylosing spondylitis, which is inflammation of the sacroiliac joints. I'll show you a picture in the next slide that shows where the sacroiliac joints are, and the spine with ankylosing spondylitis. Sacroiliitis occurs a bit more commonly. So sacroiliitis alone occurs in about 10 to 20% of IBD patients. That 20% often is looking at radiologic or imaging findings of sacroiliitis, because some people with sacroiliitis can be asymptomatic, can be without symptoms. Ankylosing spondylitis is when this also includes the spinal joints or the spine, and that's a little bit less common. That occurs probably in about 2 to 4% of IBD patients. The axial arthritises tend to follow a course independent of bowel inflammation, and they tend to be diagnosed, or they're almost always diagnosed with some degree of imaging finding, as well as symptoms of inflammatory lower back pain. Next slide. So these are some examples of these imaging findings, and these can be a little bit tricky to look at. But in the top, if you see the black boxes near those hip joints, the hip crests, that is where the sacroiliac joint is, kind of where the pelvis meets the spine. And if you can see this in the normal picture, there's a pretty nice view that you can see the joint space there. You can see a little space within that area. Whereas in the diseased picture, the sacroiliitis picture, you see that there's just kind of a dark white mark, kind of an inflamed area there between that joint space. Next slide. Ankylosing spondylitis, this is an example kind of an imaging finding of this. You can actually see changes of sacroiliitis in the ankylosing spondylitis picture as well, but you also see, compared to the normal spine, you also see kind of loss of the kind of darker joint spaces within the spine, and it looks very straight and very fused. That's what we call that imaging finding a bamboo spine, which is classic of ankylosing spondylitis. We can go to the next slide. So when we think about treatment, which is very important, of peripheral arthritis versus axial arthritis, we think kind of mainly about how these affect the body and also whether they're following bowel inflammation. So peripheral arthritis, although there is some exception to that, tends to follow gut inflammation. Fortunately, it's usually not chronic or erosive. It generally does not cause joint damage. And most often, again, there are exceptions, treatment of the underlying gut inflammation is kind of the first step, and that's often sufficient to treat IBD-associated peripheral arthritis. Axial arthritis, on the other hand, can follow a course independent of gut inflammation. Particularly, ankylosing spondylitis can be progressive with structural damage and disability. And often patients with axial arthritis should be jointly managed with a rheumatologist. And these are often treated with biologic therapy, traditionally the anti-TNF agents, and more commonly the JAK inhibitors. Or not more commonly, more recently, the JAK inhibitors, I should say. Next slide, please. So we'll move on to skin manifestations. Next slide. There are two main types of skin manifestations that are directly associated with inflammatory bowel disease that we'll talk about today, and those are erythema nodosum and pyoderma gangrenosum. It's important to note, though, that there are other skin conditions, such as atopic dermatitis and psoriasis, that are more common in IBD than the general population. But these tend to be kind of separate entities, so we won't talk about those today. They could probably be a talk of their own. Next slide, please. So erythema nodosum is slightly more common than pyoderma. It occurs in roughly about 5% of IBD patients. It is more common in Crohn's disease and tends to be a little bit more common in female patients. It presents with a fairly classic rash with red, tender nodules. They tend to be a few centimeters in diameter, and they're most common on the lower extremities, such as on the shins, is where we often see them. And they're exquisitely painful. And that's a very classic picture for erythema nodosum. The diagnosis can often be made just by the characteristics of the lesions themselves, and they rarely require a biopsy for diagnosis because they do have a classic appearance, but occasionally that's necessary when the diagnosis is in question. Erythema nodosum very much parallels intestinal disease activity, and generally treatment is focused on treating the underlying disease and treating the underlying IBD. Although erythema nodosum it can be exquisitely tender, and it's also a sign that usually the bowel disease is very active. So often corticosteroids or things like prednisone may be necessary to get both the bowel disease under control rapidly, but also control the symptoms of the erythema nodosum. And it is notable that erythema nodosum can occur with non-IBD diagnoses as well. Next slide. Next is pyoderma gangrenosum, and pyoderma sometimes can be somewhat hard to look at because it is an ulcerating skin lesion. So pyoderma classically kind of presents as small papules or a small ulcer, but can progress to a deeper ulcer and can occur anywhere on the body, but it does classically happen at sites of trauma. It also can occur at shins just because it's a common trauma site. And in IBD, we see it, unfortunately, not uncommonly kind of around the sites of stomas, which tend to be areas where there is some trauma over time. It is a bit less common than erythema nodosum and probably occurs in about 2% or less of IBD patients. Pyoderma, unlike erythema nodosum, can occur independent of intestinal disease activity. And sometimes we see this kind of going onward despite kind of complete eradication of disease, such as in UC after a colectomy. Sometimes we see it even around that stoma site after a colectomy for UC. Treatment involves immunosuppressant, and oftentimes those immunosuppressions do overlap with IBD treatments. We use often biologic agents to treat these. Treatment is often in collaboration with the dermatologist. Dermatology will often help with topical therapies like topical steroids or topical tacrolimus. And these lesions do ulcerate, so it's important to remember that sometimes significant wound care is needed to help these heal and to keep them from getting infected. Next slide, please. So we'll move on to mouth symptoms. This is the shortest of all the categories. Next slide. When we think about mouth extraintestinal manifestations of IBD, we're mainly thinking of aphthous stomatitis. Aphthous stomatitis presents as painful mouth ulcers, and these are commonly called canker sores. That's what I kind of grew up learning to call them. They certainly can happen in other conditions, but they're rather common in IBD. Aphthous stomatitis tends to follow intestinal disease activity. They tend to be present when intestinal disease is active and tend to improve as we treat the underlying disease. So treatment generally involves treating the underlying IBD and getting the luminal disease under control. But we can also use topical treatments to help with discomfort because these also can be very painful. We sometimes use I use something called magic mouthwash, which is a mouthwash that includes some lidocaine and other numbing agents to help with discomfort while these are healing up. Next slide. Moving on, I promised that one would be short. Moving on to eye manifestations. There are two main eye manifestations that we'll talk about today, which are episcleritis and uveitis. The eye is very complicated, so I tried to include some kind of images of eyes so that we can remind ourselves how complicated it is. Episcleritis is kind of the less dangerous of the two ones that we'll talk about today, which is good. It generally presents with redness of the conjunctiva and the sclera, which is the outermost kind of white portion of the eye. It's the outermost portion of the eye, which is why it's less likely to cause kind of damage to the eye. It's generally painless, but not completely asymptomatic. You can have some itching and burning that comes along with it. It does not result in visual changes, which is good, and it does not cause eye or vision damage, which is also very good. Episcleritis tends to come along with IBD disease activity. So treatment is generally focused on treating the underlying IBD, but also same kind of trend, topical agents such as topical steroid eye drops and things like that can be used to help with symptoms while we're getting the disease under control. Next slide. Uveitis, on the other hand, can be a serious eye condition. So uveitis presents with eye pain, blurred vision, headache, or sensitivity to light called photophobia. And you can see that eye picture. That's a little bit scary. I think most of us would know that if our eyeball looked like that, we'd probably be, and was painful and losing vision, we would know to kind of seek help. Uveitis can run independent of IBD disease activity, and it can happen in both eyes, and it can be associated with other extraintestinal manifestations like joint pains commonly come along with it. Uveitis is serious and has the potential to lead to loss of vision. And that's in part because it's an inflammation of the deeper structures of the eye. It can affect the retina, the vitreous area of the middle of the eye, as well as the uvea, which it's named after. Somewhat fortunately, there are different types of uveitis. The anterior type is more common, and posterior is more likely to cause vision loss. Fortunately, it is less common. So that is one positive point. Next slide, please. So when we think about treatment of these conditions, again, just like the common theme of this talk is that we're thinking about how they behave compared to IBD disease activity, and how they affect the body. So episcleritis generally does not cause vision damage, so it's less of an emergency. Episcleritis actually sometimes can self-resolve. As I mentioned, it's also often treated with topical agents that can help with symptom relief, like topical eye drops. And one of the main treatments is to treat the underlying IBD. Uveitis, on the other hand, has the potential to cause vision damage, so it can be a bit more of an urgency or emergency. It should be treated by an ophthalmologist with expertise in this area in collaboration with a gastroenterologist, and that's because it does have the potential to cause vision damage. And it's often treated with immunomodulatory or biologic agents, much like IBD. I find that these sometimes when you see a big red eye, sometimes it's hard to know when to be worried, because the eye is a little outside my area of expertise. So just emphasizing kind of when in doubt, eye pain, significant pain, sensitivity to light, blurring, or particularly vision changes can be a sign of more severe eye disease and should be evaluated. Next slide, please. So we'll move on to liver manifestations, and I think this is one of the last of the big categories that we'll talk about today. The first liver manifestation that we'll talk about is primary sclerosing cholangitis, or the main one that we'll talk about is primary sclerosing cholangitis. But thinking broadly about hepatobiliary disease and IBD, which is disease of the liver and bile ducts, liver function tests or altered lab abnormalities in IBD of the liver are very common. Up to 30% of IBD patients can have altered liver function tests. These can include a number of diagnoses. These can just be liver disease is common in the population, or liver test abnormalities is common in the population. So all the other stuff can affect IBD patients as well. But IBD patients can also be somewhat particularly susceptible to drug-induced liver injury because we're often exposed to a lot of medications. And primary sclerosing cholangitis that we'll talk about today. Primary sclerosing cholangitis, or PSC, is the most common IBD-specific liver disease. About 5% of IBD patients have PSC. It's not super common, but it definitely does exist in the population. However, if you look at a group of patients with PSC, the vast majority of those patients will have IBD. So 70 to 80 or even more percent of patients with PSC have IBD. So this is one of those conditions if PSC is diagnosed before IBD is diagnosed, it often prompts some consideration and workup of IBD. Next slide. Primary sclerosing cholangitis is inflammation and fibrosis of the biliary tree or the bile ducts and can lead to these visual kind of irregularities of the bile ducts. On imaging, as well as kind of more invasive procedures like ERCPs, those ducts can show areas of narrowing and dilation because of inflammation and kind of scarring. It typically presents with elevations of the liver tests, and it generally is asymptomatic or without symptoms when it presents. And one of the more common things that's elevated is alkaline phosphatase, but other liver tests like AST and ALT are also commonly elevated. It's more common in men than women. It's one of the few that is. And PSC does occur independent of intestinal IBD. So this is one that can progress even after disease is well controlled or even after a colectomy for ulcerative colitis. The treatment for PSC is largely supportive and should involve kind of referral or collaboration with a specialized hepatologist if there's evidence of significant disease progression in particular. Next slide. One of the most notable points about PSC for us, for our luminal gastroenterologists, is that PSC increases the risk of dysplasia or precancer within the colon and progression to colon cancer. That risk is about fourfold that of baseline in IBD, and as we know, IBD is a little bit higher than the general population. So generally, when PSC is diagnosed, that triggers the start of surveillance colonoscopies, generally yearly, once that diagnosis has been made due to the significantly increased risk. Next slide. And so briefly here toward the end, I'll just briefly touch on what is a really common question in clinical practice, which is when we look at all these extraintestinal manifestations and we have symptoms and we think, well, is this an extraintestinal manifestation or is this something else like a medication side effect? So sometimes a few medication side effects can be similar to symptoms of extraintestinal manifestations. Probably the most common one of these that I see is joint pains, because joint pains are the most common extraintestinal manifestation, but they can also sometimes occur due to medication. Similarly, rashes can be due to medication, and skin findings are also extraintestinal manifestations. This one's a little less tricky because the skin findings that are extraintestinal manifestations of IBD are often very classic and very different in appearance than rashes that happen because of drugs. Other times, a medication side effect can present with similar laboratory findings as an extraintestinal manifestation. For example, liver test abnormalities can occur following the start of a drug. But liver test abnormalities can also be, the first kind of thing that we see to diagnose primary sclerosing cholangitis. So sometimes this is very complicated, and this is going to be a very brief discussion because this really is a kind of an in-depth conversation with your physician. But some of the things I think about and some of the things that your care team will think about if this is in question. One of the first main things is what's the time of symptom onset in relation to IBD, as well as the medication start. So someone that's had joint pains associated with their IBD for years and years and years, who starts a medication and is still having joint pains, that might be a sign that the medication is not working very well, but it's probably not because of the medication. That sounds more like an extraintestinal manifestation. Whereas someone that's never had joint pains at all and suddenly has kind of severe joint pains after starting a new medication, that is more likely to be related to the medication. We think about whether symptoms have come along with intestinal symptoms previously. I think about what is the characteristic of the EIM in question and whether it tends to parallel disease activity. If it does, do I have evidence that there's active intestinal inflammation that needs to be treated? And if so, that probably needs to be treated accordingly. And some findings just warrant additional testing and treatment because they're either concerning or severe, or because other organ specialists can be helpful with this, such as lab abnormalities. Sometimes we have to bring in other specialists. Next slide. So we'll wrap it up a little bit. Hopefully I haven't taken up too much time so that we have plenty of time for questions as well. So for our conclusion, in conclusion, we'll summarize a few points for today. We can move on to the next slide. So extraintestinal manifestations overall are very common in IBD, and they can start before luminal symptoms start as well. Treatment for extraintestinal manifestations generally depends on whether the extraintestinal manifestation runs parallel to luminal disease or whether it runs independent of luminal disease or intestinal disease activity. Those EIMs that parallel disease activity, the mainstay of treatment is to treat the underlying IBD. And we don't forget about symptoms and things like that that we can control and help with as we're treating the underlying IBD. But the mainstay of treatment is to treat the underlying IBD. For those manifestations that have the potential to run a course independent of IBD, we will often work to treat both the extraintestinal manifestation and the IBD. If we can treat those together with a single medication, that's ideal. But sometimes we have to kind of treat multiple things at once. And fortunately, most therapies used for EIMs are kind of those immunomodulatory and oftentimes biologic agents, which can also be used to treat IBD. Extraintestinal manifestations that do not follow intestinal inflammation or that have the potential for serious consequences often need to be treated in a multidisciplinary manner with a specialist of expertise in the organ system that's affected. And then on the final slide, I'm not going to go through this in great detail because we've already talked about each one of these, but this is just a quick reminder of kind of the extraintestinal manifestations that we talked about today and whether they tend to take a parallel course or a separate course to disease activity. And that's all I have. So we'll, I guess, move on to questions.
Thank you, Dr. Scoville, for that very informative presentation. I know that I learned a lot, so let's see how much you learned. At this time, we'd like to resubmit the 2 questions that we had in the beginning of the program to see how much you have learned. Please make your selection to the 2 questions on your screen now. Again, the first question is, are symptoms outside the gut more common in Crohn's disease or ulcerative colitis? And the second question, what is the most common IB symptom outside the gut? I'll give everyone a few seconds to make their selection. Awesome, everybody was paying attention. The correct answer for our first question is Crohn's disease. We've learned that rates of extraintestinal manifestations are high in all individuals with IBD. However, they are slightly more common in patients with Crohn's disease. For our second question, say if we got almost a 100% on this test, the most common symptom outside the gut is peripheral arthritis. We've learned that peripheral arthritis does not typically involve joint damage, and treatment typically follows treating the underlying gut inflammation. Thank you for taking that quiz with us. And now let's direct a few questions from the audience to our expert presenters. I'd like to welcome Dr. Alexander Levy onto the camera, who has been answering questions for us throughout the chat. If you have a question for Dr. Scoville or Dr. Levy, please type it in the Q&A box, which can be found at the lower part of your screen. Our first question is for Dr. Scoville. There were a lot of comments in the chat about patients suffering from frozen shoulder. Is this condition common in IBD?
To my knowledge, it is not necessarily more common in IBD that I'm aware of. Certainly various arthritises can, and inflammatory arthritis, sorry, that's my dog. um, uh, Inflammatory arthritis is more common in IBD. So it is conceivable that having kind of inflammatory arthritis could increase your risk of having a frozen shoulder, because if you have joint injury or something like that, I can see how that might kind of correlate. But to my knowledge, I don't think the actual frozen shoulder is necessarily more common in IBD.
Thank you. Dr. Levy, there were a few questions in the Q&A about getting EMIs after you are in remission. If a patient remains in remission for a longer period, does that lower the chances of them occurring?
So yes, for certain ones. So I think Dr. Scoville mentioned in her talk that certain EIMs go in parallel with disease activity. So presumably if that person is in remission, then they're less likely to have those. However, there are other ones, so like PSC, for example, being one, where it doesn't parallel the disease activity, and that can unfortunately occur even in somebody who's been in deep remission for quite some time.
Thank you, Dr. Levy. Dr. Scoville, we have a question about diet. Could following any specific dietary approach help prevent or reduce symptoms that extend beyond the gastrointestinal system? I think that's a common question.
Yeah, so I think in so much as diet can kind of affect disease activity in luminal IBD, particularly for those that follow intestinal disease activity. So kind of anything for those extraintestinal manifestations that do follow kind of parallel that course, anything that improves intestinal disease activity is a little bit more likely to improve those symptoms as well. Um, so I there's for those that don't parallel disease activity, there probably aren't all right, there aren't to my knowledge kind of specific diets for those that don't parallel disease activity. Although there may be situations, for instance, like significant liver disease and things like that, where diet can kind of play a role in managing that condition, but probably not in prevention or kind of treatment.
I agree.
Thank you, Dr. Scoville.
Mhm.
Dr. Levy, you didn't mention fatigue as a symptom outside the gut, but many people in IBD experience this. Is chronic fatigue, even in remission, common, and is it treatable?
So fatigue is something, it's probably the most common symptom that our patients will report. More than diarrhea, more than pain, it's fatigue. And I think the initial challenge is trying to figure out what is the primary cause, hopefully one that is modifiable, right? And so we look at things like anemia, right? Are they iron deficient, right? Is their disease active, right? Are they waking up because they're having to have multiple bowel movements, right? I mean, for other people, it's because they also have sleep apnea and they're waking up for different reasons, right? They have a barking dog, right? So there's a million reasons. And, I mean, I can talk about, different psychiatric issues, stress, anxiety. So point is a lot of different things, right? We try as gastroenterologists to figure out which ones can we actually change. And obviously we treat the underlying disease. We look for anemia, we transfuse, we give iron, right? There was some, but it's a very, very common symptom from our patients. And we do our best to try to figure out what's the underlying cause. And sometimes, unfortunately, we don't. There was some data and maybe looking at thiamine, and maybe that has a benefit in fatigue for some patients, even if they're not necessarily anemic, but giving iron for iron deficiency without anemia may have a benefit if just specific to fatigue. But a lot of the other, many times I can't find that, that exact source. So it kind of perplexes us frequently. I don't know if Elizabeth or Dr. Scoville, you've had a similar experience.
Yeah, I completely agree with all that. We're always trying to find kind of an underlying reason that we can treat. And I really often emphasize to my patients that when you do have active inflammation, that is a profound source of potential fatigue. So we really have to get that under control. Treat, as you said, anemia and all of those things. But there are a portion of patients that we kind of do everything we can, and there's still kind of fairly significant fatigue. We all see this. I have also tried kind of thiamine based on that study in some of my patients. We have a functional medicine clinic that I'll refer to, which is really a blessing in my center to work on kind of sleep and habits and things like that, which can be really helpful. But fatigue is very, very common and very, very challenging sometimes.
Thank you. Dr. Scoville, What is the relationship of UC with recurrent pericarditis?
Ooh.
I
Uh,
like it. I saw that. I was gonna decide if I was gonna type that in or not.
yeah. Oh gosh, I don't know. Um,
If you want me to
yeah.
chime in,
Yeah, go for it.
I think there are some small studies looking at pericarditis and myocarditis in IBD. So it's possible that in certain individuals it may be an extraintestinal symptom, particularly if you can't find a more common cause. So if, because oftentimes they're looking for, viral infections and some of these other things that can cause inflammation of the heart or of that kind of sac around the heart. There was also some data in terms of some of our treatments and the risk for pericarditis. However, I think most of those kind of boil down to just increase in the risk for the infections. So viral infections in particular that are probably one of the most common causes of pericarditis. I think that is maybe the highest risk. But it's possible that for certain individuals, and I've had a couple where in young people that otherwise had no reason to develop this, that it may be an extraintestinal symptom, but it's not, or manifestation, but it's not a common one.
I've also seen it associated with drug-induced lupus. Um, Not an EIM, but
Thank you. Dr. Levy, what do you recommend for patients who are on biologics, but it's not helping the arthritis in the knee? What do you suggest patients do?
So I think this is always a great opportunity to think about either combining certain treatments with whatever their primary treatment. Um, Other options, you can always seek a referral to a rheumatologist and in collaboration, GI plus rheum, finding something that either works with whatever you're using for your IBD, or in some cases, we're actually switching therapy, acknowledging that we risk potentially losing whatever we gained with our IBD therapy, but hoping to gain an additional benefit, which is treating the joint disease. So that's not an uncommon thing, and it's a big decision, especially if you're going away from a drug that has worked for you for quite some time. But there are cases where that is essential if some of these other options aren't working.
Thank you, Dr. Levy. Dr. Scoville, a few patients mentioned having dry mouth. Is this a common symptom and what would you advise?
um, it's not as it's not necessarily a common symptom, but I think one of the main things that I would think, one of the first things that I would think about with dry mouth is medications. So a lot of medications can cause dry mouth as part of kind of what we call an anticholinergic kind of picture. So probably one of the first things I would think about with dry mouth is thinking about medications and things like that. Things like some of the more common anticholinergic medicines that we'll use in IBD or in GI are things like dicyclomine, that but usually in very high usually a little bit higher doses, but everyone's different. But that's certainly not the only one. There are kind of uh, immune related kind of dry mouth or conditions that can cause dry mouth. And certainly we know that folks with IBD are more common to have other kind of immune related conditions as well. So that's certainly kind of within the realm. But I think the first thing I would think about really is kind of ruling out and thinking about medications.
Thank you. And same question to you. Many gastroenterologist practices offer virtual appointments. How do providers ensure that patients are doing well, including vital signs, skin conditions, or any other symptoms beyond the GI tract?
This is something I certainly struggle with kind of as we have kind of become more and more in tune with, but also kind of dependent on virtual care. Virtual care is very helpful in my practice where we are in kind of a tertiary referral center, and it is incredibly helpful for patients that are driving, many, many hours. But it is always a concern of mine that, we're not necessarily getting as full of an exam. We may not be getting vital signs and things like that. So some of the way that I address that in my practice is that I do ask that my patients be seen kind of periodically in person, even if they're doing well. And and trying to kind of tease out these things. If I hear or kind of I have a message that's coming in that I know that there's a rash or something that I'm worried needs to be kind of really clearly visualized. Same thing with kind of perianal symptoms, not really a discussion for today, but rashes, perianal symptoms, things that I really know that I need to look at. I will ask people that kind of come in if we can triage that ahead of time. But it is a really valid point in kind of knowing to, as kind of your own advocate, that when we are doing virtual care, that we can't get as good of an exam, and we worry about these things too. So if you're worried that something needs to be kind of visualized or examined, joints kind of swelling, things like that are really hard to pick up virtually. Advocate for kind of in-person visits as well when you need those.
One of the things I'll add, at least for rashes, is that sometimes these things pop up, and then by the time you get the visit, they're gone.
Yeah.
Take a good photo, right? Sometimes it's like, oh yeah, you tell your doctor, and you're like, all right, we'll see you, and try to get you in by the end of the week, and oh yeah, rash went away, and then 5 days later it comes right back, and you're like, so taking a nice photo, at least that way when you come to that visit, they can at least see, what may have been there, can at least help guide kind of what to do next. But I agree with Dr. Scoba. It's hard. A lot of these things, you can't examine a joint. Like how can I tell you if it's inflammatory versus osteoarthritis via video? That's virtually impossible. No pun intended.
Thank you. Dr. Levy, there are some questions about taking supplements or complementary therapies to help with EIMs. Are there any that you recommend?
Specific to EIMs, I mean, the data is pretty sparse. I think there was some data looking at things like curcumin, for example, and that's been used and looked at for UC probably a bit more, although there is some data also in Crohn's disease. But for joint disease, I think there was some data. I don't think it was particularly strong, but those studies were quite small. So I don't think there's necessarily any specific supplement or complementary therapy that's been targeted towards extraintestinal symptoms. Again, fortunately, a lot of our conventional therapies are great for extraintestinal symptoms. We do know that certain ones tend to treat certain EIMs a little bit better than others, and that again also helps to guide the treatment choices. But with complementary therapy, it's pretty limited. Doesn't mean it can't work. It just means we don't have a lot of information to specifically make a recommendation.
Thank you. Dr. Scoville, would surgery for UC patients to remove the colon potentially cure EIMs?
Yeah, so I think of this question kind of as those that go along with disease activity versus those that don't. So a colectomy done for kind of active or uncontrollable ulcerative colitis is essentially kind of taking away the inflammatory burden of that inflamed colon. And essentially treating the ulcerative colitis. So I would expect that those EIMs that very closely follow disease course to improve after colectomy, whereas those that don't necessarily follow that course, I could improve, but wouldn't necessarily be expected to improve. So the example, kind of classic example being like PSC. PSC generally does not improve after colectomy. It kind of follows a very independent course. Whereas people with things like joint pains that run kind of along with luminal disease activity do tend to get substantially better after we take away that inflammation.
Thank you. And I'm not sure if I pronounced this word correctly, but Dr. Scoville, is collagenous gastritis related to IBD? Because, oh, I'm okay. That was a personal question. Okay. Give me 1 second. Final question. Dr. Levy and Dr. Scoville, what would be your recommendation to all our patients who are suffering from EIMs and haven't gotten relief?
So I think there's many reasons why EIMs may, you may not be getting relief from EIMs. I think kind of going back to kind of thinking about whether this is something that parallels or doesn't parallel disease activity, because that kind of helps us, there are exceptions, but that kind of helps us hone in on how we could potentially better treat this. So those that parallel disease activity, if the IBD is active, kind of working with gastroenterologist to kind of more aggressively, if possible, treat the underlying IBD sometimes makes a huge difference. For those that don't parallel disease activity, if particularly if you're not making progress with your gastroenterologist and you're still having a lot of symptoms, we're specialists in the gut and we're specialists with the lumen. So if we're not making progress on those or the others for that matter, kind of seeking out a little bit more help with a subspecialist of choice, whether that be kind of a rheumatologist, an ophthalmologist, an eye doctor, a dermatologist. They have a lot more expertise in using kind of symptomatic therapies, those topical therapies that can really, really help out and can sometimes kind of make or break symptomatic care.
I definitely agree. I think, IBD is truly kind of a systemic, kind of full body disease. And I rely on so many colleagues to help me out with all these extraintestinal symptoms, complications, right? So we work closely with rheumatologists, dermatologists, ophthalmologists, all the ologists, right? Because we can't treat everything, right? We do our best, and in many cases, our treatments do have an impact on these other extraintestinal issues, but frequently they don't. And it's important to have that good team built around you to ultimately, reach your goal, right? And I think that's probably the biggest thing is just knowing when to ask, right? I mean, that's probably a bigger issue for your provider, but even as a patient, advocating for yourself in that, as Dr. Scoville mentioned, if it's not working out with your gastroenterologist, maybe say, hey, like, could you send me to a rheumatologist and see if maybe they have some additional thoughts?
Thank you both so much. It was a great discussion. Thank you. As our program comes to an end, on behalf of the Crohn's and Colitis Foundation, we encourage you to keep learning about IBD and to visit our helpful educational resources. To learn more about everything we discussed this evening, please visit the Foundation's web pages on extraintestinal symptoms and pain and fatigue. The QR codes on this screen will take you directly to those specific websites. If you're looking to connect with other patients and caregivers, the Foundation offers virtual and in-person support groups. The QR code at the bottom right of your screen will help you locate a support group near you. The IBD Help Center is there to provide information and resources to patients, caregivers, and healthcare providers about inflammatory bowel disease. They're available by phone or email, as well as live chat, currently available Monday, Tuesday, and Thursday. Finally, to watch previous webinars and expert conversations, please visit the Crohn's Colitis Foundation.org/MyIBD Learning. I want to remind everybody to please fill out the evaluation survey that will be sent to you after tonight's program. We really appreciate your feedback and it will help us plan future programming. Thank you again to our presenters, Dr. Elizabeth Scoville and Dr. Alexander Levy, for joining us tonight. Have a great evening.